Everyone, on behalf of WHO, I'd like to welcome you on this new webinar of the TeleECHO webinar series focused on scaling up services for children and adolescents living with HIV. Today, we'll be talking about comprehensive package of care for infants and young children who are exposed to HIV. As usual, I remind you that this webinar is translated into 2 languages. You can select French or Portuguese as you like, and as you see in this slide. Also, if you do have any problem, please do get in touch with the ECHO colleagues that are online. And we would appreciate if you could rename yourself so that we can take note of who is joining. Also, please note that this session is recorded, and so your attendance provides consent to be recorded. And be mindful that the presentations will be shared at the end of the webinar together with a recording link. We also would love to have to hear your voice and to collect your questions and thoughts. And we would appreciate if you could use the chat box for general comments to panelists and attendees, but use the Q&A function for any question that you might have, because that will help us to really address all of them during the course of the webinar. As you know, these webinars were intended as a platform to really provide information sharing, but mostly to promote interactive discussion and really address and discuss progress, but also pending issues that require intervention at a country level. And the overall goal is very much to flag challenges, but most importantly, share solutions and trigger technical assistance by various stakeholders, both at the global and at the regional level. As you know, we are building on work that has occurred over the last 2 years on different rounds of webinars and meetings that we've had. And this most recent one is giving us the opportunity to review a number of key issues and continue to monitor what's happening on the ground with lots of different stakeholders connected with us today on the line. From policymakers, from technical working groups in countries, as well as frontline workers. So we're really happy to really have this broad forum with us to discuss some of the topics that we have today. So as you know, WHO released updated consolidated guidelines in July 2021, and hopefully many of you have had the chance to look at these guidelines online and have already been exposed to some of the new elements of these guidelines as part of previous webinars on this series. There are a number of derivative products that are being developed, policy briefs and guidance documents that are being developed alongside these guidelines to really support adoption, adaptation, and implementation. And one of the products that we anticipate to launch in December it relates to the comprehensive package of care for infants and young children that are exposed to HIV, which will be the focus of the conversation today. So as you've seen, the agenda that we have today is really exciting with a lot of really great contributions by very different colleagues. We'll start off by reviewing a few elements related to the comprehensive package of care to anticipate what you will find in the policy brief, and then move on to discuss a little bit more in detail the aspects related to the use of cotrimoxazole in HIV-exposed infants with the support of Dr. Catherine Wedderburn from the MRC UK and University of Cape Town in South Africa that will take us through some of the evidence as well as the considerations that have been generated through a number of technical consultations over the last year or so. We'll then have the pleasure to have an expert panel with a number of colleagues that have contributed to this work over the last years and decades in some cases. And so I really welcome Professor Andrew Prendergast from Queen Mary University in London in the UK, Professor Diana Gibb from the MRC Clinical Trial Unit at UCL UK, Professor Amy Slogrove, Stellenbosch University, South Africa, and Dr. Jane Mutanga from Livingstone Central Hospital in Zambia. So a lot of great perspective there that will help us to dive deeper into the use of cotrimoxazole for HIV-exposed infants. We'll then switch gears and focus a little bit more about postnatal prophylaxis. Ivy Kaziria will take us through some of an overview about what's happening on the ground right now, but we'll hear that directly from a number of colleagues from various countries, Danielle Simon-Nem from WHO Cameroon, as well as Dr. Francis Ndwiga from NASCO Kenya, and then Dr. Teresa Beatriz Simeon from Misao in Mozambique, that will all share their experience with the use and implementation of postnatal prophylaxis in their country. We'll then move on with another expert panel with the support of two colleagues that have been involved in developing some of these recommendations over the years, and most recently involved in work that is looking at the future of postnatal prophylaxis in countries. And so we'll have Professor Lane Abrams from ICAP at Columbia University and the Impact Network, as well as Professor Theodore Rule from the University of California, San Francisco in the United States. And we'll wrap up as usual. So I'll start off our program today just by reminding you that obviously we do have progress, and progress is tangible in a number of different places and countries in sub-Saharan Africa. But there are gaps that are remaining, and obviously that's what we need to keep in mind. We know we have about 1.3 million pregnant women that are living with HIV, and a large proportion of them are receiving antiretrovirals, and we're receiving antiretrovirals by the end of 2020. But despite that, there's still about 150,000 new vertical infections that are occurring, and most of them are in the sub-Saharan Africa. We know that as a result, we can estimate to have 1.7 million children living with HIV, and we know that we're only reaching half of them with the treatment that they need. Now, we know that identifying them quickly is the key to success and to making sure that we can provide them the care that they need. But we know that there is persisting attrition along the PMTCT-EID continuum, and we know that 49% of women living with HIV in sub-Saharan Africa are lost between ANC registration and delivery. And about 34 of infants that are lost to follow-up by 3 months, and further proportion is then lost to care after the test before definitive diagnosis is reached. So a number of points in the continuum of care where we unfortunately are unable to retain patients and mom and baby pairs in the system to be able to fully assess their health outcomes. We know also that as programs are maturing, vertical transmission of HIV is evolving. Approximately, there is half of the new infections that are happening in children that is occurring in the postnatal period. And we know that vertical transmission is primarily due to maternal seroconversion during the breastfeeding period, or to lack of adherence in a time where women often struggle to be adherent to their medication. We know that prevention of vertical transmission depends very much, therefore, on identifying maternal infection early and rapidly reaching and sustaining maternal viral suppression. We know we have an integrated package of care and several interventions that can be used to not just address and prevent HIV infections, but also to address the morbidity and mortality that affects children and infants and children beyond HIV infection per se. And we know, however, that some of these services are often fragmented, and there's multiple services points, multiple providers, and clinic days, and that's not supportive of effective and successful scale up and achievement of optimal outcomes. So integration of health services is an important strategy to improve access to care, but also to find more efficiency and cost effectiveness of service provision and patient satisfaction. So the package of care that we'll be discussing today is very much an integrated approach that combines effective intervention along the continuum of care in an harmonized package, and really is aimed at simplifying implementation and increase access to services that have as an overall goal HIV-free survival and optimal development for HIV-exposed infants. So if we keep that in mind, our package of care is comprised by a number of different interventions. There are interventions that relates to the mother. We talked about identifying maternal infections, as well as ensuring that women are provided with treatment and monitored so that they can remain suppressed as much as possible. We also know there is a number of services that are geared to ensuring early childhood development and supporting that through a number of different touch points with the health facilities. Cotrimoxazole is an intervention that has been used for a very long time to prevent PCP pneumonia in children that live with HIV, and know that is provided to children that are exposed to HIV in the event where HIV infections might not be identified in a timely manner. Postnatal prophylaxis then remain a critical intervention to address that remaining transmission that can occur around delivery and the postnatal period. And we know that we do have a number of other interventions that are that refer to the routine postnatal care that is provided to infants in this age group, including immunization, growth and developmental monitoring. And finally, infant diagnosis that has critical time points for undertaking virological tests, and then to ensure final diagnosis once the at-risk period is completed. Now, we're trying to capture some of these interventions in the time horizon and over the first 2 years of life of these kids. And so we are describing the package of care with a number of time horizons and lines that you see here. And you can read this graph by referencing really the different time points that you see in the course of the first 24 months of life in children. And the first interventions that we are displaying here relates to HIV testing in the mother that should be repeated, particularly in those that are at high risk for acquiring HIV infection. And that is a primary way to really identify in a timely manner maternal infections, as we said earlier. We also have a revised and adapted viral load monitoring algorithm that helps to support more frequent viral load in pregnant women in the postnatal period. And as you can see here, the first one to be conducted 3 months post-ART initiation. So there's then a number of interventions that are delivered to the infant that you can see summarized here. And we'll start from infant diagnosis with the classic time points that are part of the WHO recommended EID algorithm. And a reminder that final diagnosis can only be achieved by testing at the end of the at-risk period. We then have cotrimoxazole provision that starts typically at 6 weeks and then continues for as long as the at-risk period. We then have postnatal prophylaxis, and depending on whether the infant is a low risk or high risk for transmission, different duration and regimens are currently being recommended for these infants. And in some countries, we've heard there's been adoption of an extended prophylaxis approach that goes throughout the breastfeeding period. Early childhood development is important throughout this period, and so interventions to support early childhood development and to implement nurturing care needs to be provided throughout, similarly to the routine care that you see illustrated here with this yellow line that really helps us to remind ourselves how many important interventions need to be provided to these children in this time horizon. Of course, as children are identified as living with HIV, they would need to start on ART. And here you can see some of the elements that obviously continue, similar to what we've just described, and importance really to adapt and the care that are needed for these children to ensure that provision of ART is supported with the right monitoring, the right support, and that is adapted over time as the child grows. So overall, we know that this package of care can be implemented in countries, obviously, if there is a leadership and alignment within the relevant maternal and child and health guidelines, policies, and services. Important, therefore, that we have a framework for collaboration and integration at the national level. We also need to ensure that the key commodities are available, that there is the right funding to support this work, and that there is an effective coordination by the different aspects in the program. We know also that we need to interface this work with the evolution of some of the HIV and PMTC programs on the ground. So identifying children, of course, that are HIV exposed outside of these programs, but also ensure that we promote and we build on family-centered approach and link them with differentiated service delivery models when and as appropriate. We also know that the community role is critical here, is critical to deliver services through community-based outreaches and service delivery, but is also critical to ensure demand creation, to ensure stigma reduction, and improve literacy of caretakers. And finally, really thinking about how at times of crisis, like the one we're living through, it's important that these services are looked at and adapted as needed. We know that during COVID, children are probably among the population that suffers the most from some of the disruptions that affected services delivered at the health facility. And so ensuring that we remain agile and adapt these services when these situations occur is critical. Clearly, human resources are going to be important to consider implication for existing human resources, because we can't really just add tasks to the one healthcare worker that is dealing with all of this. And it's important that the capacity is built, but is also supported through a number of different ways of supporting and supervising healthcare workers. And finally, using other type of cadres to make sure that these healthcare workers are not overloaded with tasks. And I'll just close with the monitoring and evaluation component, because we know that what gets measured gets done. And it's important that we are able to really learn from what we're doing on the ground, that we're able to adjust our strategy as we collect data, but most importantly, that we continue to monitor progress and gaps so that other interventions or adjustment in the strategies that we deploy can really be helpful for us to be able to serve the population that we're targeting here. So there's going to be much more to discuss during the course of the agenda today, but for now I'll stop there, and very much welcome, of course, questions that you might have in the Q&A function. And without further ado, I'd like now to hand over to Dr. Catherine Wedderburn, that will take us through a little bit more of the details related to the use of cotrimoxazole and some of the most recent discussions that relates to the evidence that support the use of cotrimoxazole in HIV-exposed infants more broadly, but in particular in HIV-exposed uninfected infants. So over to you, Catherine.
Hi, everyone. Thank you very much for the introduction, Martina. I will be giving an overview of current guidance, an update of the evidence for use of cotrimoxazole prophylaxis in infants who are HIV exposed. There has been huge progress in PMTCT globally. However, vertical transmission of HIV continues to occur. Trials have shown that cotrimoxazole prophylaxis prevents morbidity and mortality among infants and children living with HIV. However, coverage of early infant diagnosis of HIV and retention in care continues to be suboptimal in many settings. Therefore, not all infants are diagnosed with HIV in a timely manner. It was in this context that the 2016 WHO guidelines recommended cotrimoxazole prophylaxis for all infants born to mothers with HIV from 6 weeks of age until the end of breastfeeding or 18 months, whichever is later. The newly released 2021 consolidated guidelines continue to recommend cotrimoxazole for HIV-exposed infants from 4 to 6 weeks of age until HIV infection has been excluded by an age-appropriate HIV test to establish final diagnosis after complete cessation of breastfeeding. However, new evidence has been released since the 2016 guidelines that has led to the addition of implementation considerations, which I'll go through now. We performed a systematic review to assess the literature for the effects of cotrimoxazole prophylaxis on morbidity and mortality in children who are HIV exposed but uninfected. And we identified 1,194 records and then ended up including 7 reports from 4 studies that address the research question. This chart shows the key studies that examine the impact of providing cotrimoxazole to HIV-exposed and uninfected infants and children. If you can see at the top here in orange is a study from Botswana, which gave cotrimoxazole or placebo to infants at 2 to 6 weeks of age until 15 months. Then the second study in green is from South Africa that randomized children at 6 weeks to cotrimoxazole or no cotrimoxazole until the end of breastfeeding. There were also, 3 reports from Uganda that examined the effect of continuation of cotrimoxazole after cessation of breastfeeding. So in these studies, all HIV-exposed infants received cotrimoxazole initially, but then on stopping breastfeeding, children were randomized to continue cotrimoxazole or not. This table shows the results, and you'll also find it in the policy brief Martina mentioned coming in December. And what you can see is the outcomes across the top of the table and then the studies down the side. And what you can see for both studies from South Africa in green and Botswana in orange, there were no differences in mortality, diarrhea, pneumonia, or combined outcomes between those children who received cotrimoxazole compared to those without. However, the study from Botswana did show higher neutropenia in the cotrimoxazole group. Sub-studies from South Africa and Botswana then examined the effect of antibiotic resistance and the microbiome. And what they showed is that cotrimoxazole prophylaxis decreased gut microbiome beta diversity and increased antibiotic resistant gene alpha diversity and prevalence, which is consistent with antibiotic selection pressure. And in Botswana, children in the cotrimoxazole group had increased antibiotic resistant bacteria. The studies from Uganda also showed no difference in mortality, diarrhea, or pneumonia between groups, but they did show that cotrimoxazole reduced malaria. Therefore, in summary, what we found is that one trial in Botswana showed no benefit of cotrimoxazole in children who are HIV exposed and uninfected. Similarly, in South Africa, the trial showed no cotrimoxazole was not inferior to giving cotrimoxazole. It's important to note that there was low mortality across these studies, which potentially limits generalizability to other higher mortality settings. Further, these studies showed that cotrimoxazole prophylaxis increased antimicrobial resistance with a potential impact on the child microbiome. The studies from Uganda showed cotrimoxazole reduced malaria episodes when continued after cessation of breastfeeding. So next, a modeling study was conducted to explore the impact of alternative cotrimoxazole strategies on mortality to 2 years of age, based on the benefits for infants with diagnosed and undiagnosed HIV. And we compared different scenarios to not giving cotrimoxazole to quantify the potential benefits. So we examined the current strategy of cotrimoxazole given throughout the breastfeeding period, and then shorter cotrimoxazole strategies between 3 to 12 months. And finally, only giving cotrimoxazole to infants with a positive test. The results are shown on this slide for the impact of the different strategies across 5 countries, ranging from those with high early infant diagnosis coverage and low vertical transmission to areas with poorer coverage of early infant diagnosis and higher vertical transmission. Please note that the model assumptions don't take into account the current South African context around testing, so I will focus more on the other countries. The bars show the absolute percentage difference in mortality compared to no cotrimoxazole use. The higher the bar, the more deaths that are prevented. And what we can see is that in all countries, the current guidelines, which are represented as the blue bar, have the largest impact on reducing mortality. However, the benefits of the current policy are greatest where vertical transmission is highest and EID is lowest, so towards the right. If we focus on one country and alter some of the model assumptions, we can see that reducing cotrimoxazole uptake from 100% to 65% lowers the impact on mortality, but this is of a similar magnitude for all of the strategies considered. In the next three scenarios, we consider situations where the proportion of infants with undiagnosed HIV increases, either through higher transmission or lower testing coverage. And what we can see is that switching away from the current guidelines to situations with shorter cotrimoxazole use results in relatively greater negative impact on mortality. So in summary, changing the current guidelines is predicted to increase mortality in all settings, but the impact of policy change on mortality depends on the context. The benefits of the current policy are greatest where vertical transmission is highest and early infant diagnosis of HIV coverage is lowest. And exploring a country-tailored approach to provision of cotrimoxazole may be of value in settings where vertical transmission is very low and PMTCT EID coverage is high. These findings also support operational research to investigate the real-world impact of shorter cotrimoxazole use strategies in countries with well-performing programs. Taking this evidence together, what we can see is that vertical transmission has declined. However, rates differ across countries. There has been substantial progress in PMTCT and EID, but gaps still persist. We know that cotrimoxazole reduces mortality and morbidity in infants with HIV infection and that it reduces malaria. However, 2 trials have now shown little to no clinical benefit for children who are HIV exposed and uninfected. And there are concerns over antimicrobial resistance and an impact on the microbiome of cotrimoxazole prophylaxis. Sorry. Given the new information, implementation considerations were developed with a technical expert group that are included in the new 2021 guidelines, and these will be further articulated in the policy brief to tease out where cotrimoxazole prophylaxis for children who are HIV exposed and uninfected may be safely discontinued. These implementation considerations state firstly that cotrimoxazole prophylaxis may be discontinued at the end of the at-risk period for HIV transmission, so after cessation of breastfeeding, which may occur before 18 months. And secondly, in settings with low vertical transmission rates, high HIV infant diagnosis coverage, and strong retention in the testing to treatment cascade, country programs may consider stopping providing routine cotrimoxazole as soon as HIV infection is ruled out. Thank you very much for listening.
Thank you very much, Catherine, for that excellent overview. We will now move on to the panel discussion. I would like to invite the participants who have questions for Dr. Catherine to post them in the Q&A function, and she will respond to them directly on that platform. Moving on to the panel discussion, I'd like to introduce Dr. Frank Lule, who is the medical officer for HIV/AIDS treatment and care at WHO Afro, the regional office. Over to you, Frank, to lead us through the panel discussion.
Thanks, Ivy. I hope you can hear me. Our lines here are messed up a little bit, but Martina already presented, introduced the expert panel that we have. We have Jane, Amy, Andrew, and Di, and they're going to share with us experiences and also areas of concern that we need to be aware of and possible areas of further study. I'll start with Jane. Jane, I have 2 questions for you, and it is just to share experiences with us on cotrimoxazole prophylaxis in Zambia, and also how you have been implementing the package of care for infants as presented earlier. Over to you, Jen.
Thank you, Frank, and good morning, everybody. So to tackle that question, I think I'll go through the points of the whole package one by one. And to start with, let's look at maternal HIV testing, treatment, and monitoring. So Zambia has a mature PMTCT program. Estimates from last year show that antenatal attendance was very high. At least 97% of pregnant women in the country had one antenatal visit. And testing, HIV testing and counseling was as high as 96%. Same-day test and treat was 95%. So we can see that the maternal HIV testing is actually very good. So those who test negative continue being screened at every antenatal visit, and they are tested throughout pregnancy and breastfeeding. So the goal here is to diagnose maternal HIV infection during pregnancy and breastfeeding and detect any incident HIV infection early enough. Now, in terms of monitoring, mothers who are on ARVs get virologic testing 3 monthly where available. And this is done with other interventions to promote adherence depending on the districts. There are various partners at work who help with programs to promote maternal adherence to ART. So when the baby is born, nucleic acid testing is done at birth or as soon as possible at first contact with the health facility. And this is to detect any HIV infection. Beyond that, testing is done at 6 weeks, at 6 months, and at 9 months. And this is actually in line with the vaccination immunization program in Zambia, and also the recommended growth monitoring for all children. So much of this testing is done in the OPD, in the health facilities in the rural areas. So care is very much integrated. The mother and baby are seen at the same time, and all the things are taken care of in one place. And we've seen that this has helped retention in care as opposed to previous models where the mother was seen in one place and the baby had to be seen in the MCH clinic. So our statistics from last year, 2020, and remember 2020, there was COVID. So many of us were worried that this would affect our PMTCT program. But what we saw was that the HIV testing continued improving from 2019. And when we look at the infants, one report suggests that HIV positivity rate at 2 months of age was as low as 0.8% in some facilities. And also at 12 months, it had gone up a little bit to 1.2%. So this does show that there is an increase in postnatal transmission. And we need to bear in mind that Zambia is a breastfeeding population. Breastfeeding is almost 97% or higher. So all infants are considered at high risk. And because of that, one of the things that the Ministry of Health has recommended is to simplify the ARV prophylaxis. So frontline health workers, the recommendation is to keep ART prophylaxis for all HIEs up to 12 weeks of age. And in facilities where virologic testing is available, the stopping rules are guided by viral load. So if the mother is virologically suppressed, ART can be stopped at 12 weeks. If they are not suppressed, then the baby needs to continue, and the mother's virologic monitoring continues as well. In terms of cotrimoxazole prophylaxis, Zambia follows the WHO recommendation where all infants are commenced on cotrimoxazole at 6 weeks of age, and this continues throughout the breastfeeding. Stopping is guided by cessation of breastfeeding and confirmation of HIV negative status. And then if we look at the early childhood development, I would say this is a sweet one because many of the components in early childhood development are implemented with external partners. For example, at the health facilities, we can demonstrate responsive caregiving There are programs where some facilities can offer play therapy or offer some support to mothers. But a lot of the other components of the package, like promoting early childhood education, that's more from the social and community structures available at the Ministry of Education and through Ministry of Local Government. So one of the things we do at the health facility is check to make sure the HIE children have access to education. So asking questions like, is this baby going to school? And if they are not attending school early enough, we can ask questions and make appropriate referrals. In terms of responsive caregiving, this is demonstrated at the health facilities. You know, many health workers are trained on how to actually show mothers what this looks like. Yeah, so, you know, there's a lot of integration that has happened in nutritional support, and all the other things are integrated to make sure appointments are scheduled and there's follow-up that goes on through electronic health records, just to ensure that red flags are picked early and mothers can be connected to care and additional support if needed. Thank you. I hope that tackles.
Thank you very much, Jane. I'm sure you've answered a lot of questions. When I saw Martina's slide on implementation considerations, it really looked overwhelming, but you've really shown that it's possible, and simplification is really key, especially in our settings. Let's move on to the next panelist, Amy. We already know that South Africa has already moved to the shorter admin protocol. Is there anything you can share with us about the experience in South Africa regarding this policy? And what do you think are the key factors that you put in place to allow that safe movement to a more limited administration of cotrimoxazole prophylaxis? Over to you, Amy.
Thanks very much, Frank, and thanks to the organizing group for the opportunity to respond to this and share a bit from South Africa. So to start with, I'd just like to be clear that currently there is some inconsistency between two guidance documents in South Africa. So the current South African national PMTCT guidelines that were released in November 2019 still advise cotrimoxazole prophylaxis from 6 weeks of age to be continued until HIV is excluded after the end of all breastfeeding. However, there was an update to the South African Essential Medicines List in November last year. And the Essential Medicines List Committee, now in light of the published studies on cotrimoxazole prophylaxis that we heard about from Catherine, revised the guidance in the EML to limit cotrimoxazole to starting at 6 weeks of age and then being discontinued once HIV infection has been excluded on the 10-week PCR test that's done in South Africa. All infants and children who are identified to be HIV infected will obviously commence cotrimoxazole and continue that. That guidance has not changed at all for children who have HIV, but the EML guidance is now shortened to between 6 weeks and probably just after 10 to 12 weeks of age for the HIV exposed and confirmed uninfected infants, even if they are continuing to breastfeed. So I think there are some really important programmatic differences in South Africa across the maternal and the infant components of the vertical HIV transmission prevention cascade that make this a reasonable change in this context. So starting with mothers, there's a lot of emphasis being put on identifying mothers who have acquired HIV during pregnancy or in the postpartum period. So mothers who are not yet known to be living with HIV are tested routinely at delivery with very high uptake of delivery repeat HIV testing. In the guidelines, they also are tested at 6 weeks postpartum and again at 6 months postpartum for HIV negative mothers. So this allows for identification of women who have newly acquired HIV during pregnancy or early postnatally. And really importantly, then this allows for their infants to be identified as HIV exposed. And so known to the program to be able to receive appropriate postnatal ARV prophylaxis, as well as early infant diagnostic testing. As well as that all in mothers, when a mother is identified to be newly HIV infected, her infant will immediately be tested for HIV to exclude that that child is not already infected with HIV. In addition, for mothers who are known to be living with HIV, there's been a shift in the guidance to routine delivery HIV viral load testing, which is also now with this sort of very defined time point in maternal obstetric care. There's been really good complete uptake of viral load testing at the delivery time point. And so what this allows for, again, is to identify mothers who are virologically unsuppressed at the end of their pregnancy, and to identify the infants who are at greatest risk for HIV acquisition. And so to put additional efforts in place with enhanced postnatal prophylaxis for this high-risk group, as well as to ensure that support is optimized and boosted to retain these mother-infant pairs in care and ensure that HIV testing is done on these high-risk infants timeously. I think also the important to note is that the early infant diagnostic testing schedule is quite different in South Africa. So South Africa has adopted birth and 10-week PCR testing, as well as PCR testing at 6 months of age, and again 6 weeks after the end of all breastfeeding, which in South Africa, for better or for worse, in HIV exposed infants will largely be before 12 months of age that they will stop breastfeeding. So this means there are multiple early opportunities for infants who are known as HIV exposed and known to the healthcare system to be identified as having acquired HIV, if this is the case. There's also a fairly well-functioning HIV PCR testing system in South Africa. So it's still laboratory based, it's not point of care, so work to be done there for sure. But if an infant is known to the healthcare system as being HIV exposed and is attending routine child wellness visits at the primary healthcare level, there are no major barriers from a system perspective to receive early infant diagnostic testing, which might not be the case in other contexts. So in the South African context, infants and children who remain undiagnosed with HIV, which is really, it's that group, it's the infants undiagnosed with HIV who this guideline stands to benefit the most. That group are largely mother-child pairs who have fallen outside of the healthcare system due to various structural challenges largely, and so will not be presenting to clinics to receive cotrimoxazole prophylaxis anyway. So I'd just like to, the other consideration was really the size of the various groups in South Africa. And I think this is just easier to visualize than me throwing a whole lot of numbers at you. So I'm just going to share quickly this just one graphic. So all this is showing is in the first bar on the left. These are the 450 odd thousand infants under 18 months of age who are HIV exposed. 435,000 of them will remain HIV uninfected. These are sort of rounded numbers from 2020 estimates just to make it easier to digest. And then expanded out into the column on the right are the infants under 18 months of age who do eventually acquire HIV. And if we look at this group in detail, the group in blue are the infants who became HIV infected during pregnancy or delivery. So these infants will largely be identified as having acquired HIV either on the birth or 10-week PCR testing. If these infants are in the program, if they're connected to care and coming and receiving healthcare, they will receive birth and 10-week PCR testing. If they are not receiving that testing, it's because they are not presenting to care, and so also would not be getting the benefit of cotrimoxazole prophylaxis. So largely, these infants are known to the system, are tested and identified early, and when they do have HIV, are started then on cotrimoxazole prophylaxis as appropriate. The yellow and the darker green groups are infants who acquire HIV postnatally, and this is really the challenging area now. The dark green group are the infants who acquire HIV postnatally, whose mothers do not know their HIV status. So that 7,500 infants are invisible to the healthcare system. They're not known to be HIV exposed. Their mothers are not known to have HIV, often only until their child is then ultimately identified as having HIV. But while they are not known to have HIV, they're also not known to be HIV exposed, and they're not known to the healthcare system. So the cotrimoxazole prophylaxis guidance will not kick in for the 7,500 infants. The 2,500 in yellow are the infants whose mothers do know their HIV status and infants that acquire HIV postnatally. And so this is the group that could derive benefit from this guidance, where there is a delay in identifying that they have acquired HIV. So we're not discounting that there is benefit for this group, but just contextualizing it as to how many infants these are. And so when all of this was sort of put together at the end of the day, in conjunction with a number of other implementation considerations in terms of what it means for the healthcare system and what it means for mothers to provide cotrimoxazole prophylaxis to their infants, there were other things that were to be considered. Confusion between ARV prophylaxis and cotrimoxazole prophylaxis, nursing care burden to provide pretty much 25% of all South African infants with cotrimoxazole prophylaxis for maybe a fairly limited benefit and no benefit for the 435,000 HIV exposed and uninfected infants. The relationship between mothers and healthcare workers. So unfortunately, the South African healthcare system can still be one that's quite authoritarian and lots of admonishment to mothers when they don't provide the interventions appropriately. And then also what was weighed quite heavily in the South African context with the antimicrobial stewardship considerations and concerns regarding the evidence that is emerging regarding potential resistance to other antibiotics beyond cotrimoxazole with the selection pressure. So I think in the end, in balancing the risks and benefits for infants who are HIV exposed, those that remain uninfected and those that do acquire HIV, it was felt that for the 15,000 odd infants under 18 months of age who are still acquiring HIV each year, investments in the other elements that optimize mother and child well-being overall, so including maternal HIV testing to ensure maternal HIV status is known, boosting support to initiate and sustain ART throughout pregnancy and breastfeeding, strengthening retention and care of mothers and infants, and closing gaps in implementation of infant postnatal prophylaxis and EID where there are gaps, would do a lot more for overall reduction in pediatric HIV and overall child well-being in this context than cotrimoxazole prophylaxis. And so I think the main question in my mind for programs is to understand how many of your infants and children who are HIV exposed are known to the system to be HIV exposed and connected to the system to be able to derive benefit of cotrimoxazole prophylaxis, yet they are not known to the system to be living with HIV. And so in settings where HIV exposed infants and children are well connected to care, but there are a whole lot of other implementation barriers to them actually receiving testing, then I think this guidance does provide a safety net. I think the situation is quite different in South Africa, where infants, if they are known to the system, they will receive testing and their HIV will be identified. The ones who are not being identified as living with HIV and those diagnoses that are being missed are largely children that are falling for many reasons outside of the system. And that's where we need to work harder to close the gaps. I'll leave it there.
Thank you. Thank you so much, Emmy. I loved that slide you showed, which you are using your data to actually make the decisions that you're making, but also the factors that need to be in place to make that transition. And I hope the participants were really attentive to that. Andrew, Emmy has eaten into your time, so I'll just give you 5 minutes for your question. And it is really just for you to say something about the concerns that have been mentioned about AMR and microbiome disruption. What is the clinical relevance of microbiome disruption and selection of antimicrobial resistance? And we have this situation of altering cotrimoxazole prophylaxis duration to further optimize cotrimoxazole prophylaxis use. But the outstanding questions, and how can we move forward in addressing these? Over to you, Andrew. 5 minutes, strictly.
Thank you very much. Well, thanks for it's an important consideration as Amy has already raised. And I think we have to recognize that the existing data we have is fairly limited. What we do have is very valuable data from the two randomized trials that Catherine presented earlier. So I think from South Africa, we have very valuable microbiome data. This trial was randomized. They collected stool samples at 3 time points and did shotgun sequencing. So that's a way of really finding out which bugs are there in the gut and the functions of the microbial community in the gut. Now, the reassuring thing from that study was that there were no major shifts in the type of bugs, the taxa that were present in the gut, or in their metabolic functions. So in other words, there was no major dysbiosis, which is the thing that we most worry about with antibiotic exposure. However, there were clear signals of increases in cotrimoxazole resistance. And those data come from 2 studies from South Africa and from the Botswana and Pepu study, which Catherine presented as well. Both studies use different methods. The South African study was using sequencing. The Botswana study did agar plate growth and disc diffusion to look at the classic cutoffs for looking at antibiotic resistance. Both were randomized trials, both had multiple time points, and both were very consistent, that if a child is on cotrimoxazole, then resistance among organisms in the gut to cotrimoxazole increases over time. So that's a very clear message. I think it's also a not unexpected message. It's what we see in HIV positive children on cotrimoxazole. And in fact, it's what we see in whole communities where cotrimoxazole is being used widely. In fact, what was striking in the Botswana study was that about 2/3 of the isolates of bugs like E. coli and Klebsiella, even without cotrimoxazole exposure in the babies, were resistant to cotrimoxazole. Now, that's been very well recognized in all the trials of cotrimoxazole over many years. And I don't think in itself, it needs to concern us so much for 3 reasons. Number one, cotrimoxazole continues to work where it's most needed, which is in people living with HIV, even when the community prevalence of resistance in common organisms is very high, 70 to 80%. So cotrimoxazole carries on doing what we want it to do. Secondly, part of those benefits of cotrimoxazole may come from anti-inflammatory effects, which are not going to be affected by resistance mutations. And then thirdly, we don't use cotrimoxazole widely as a first-line treatment intervention, apart from a few limited indications like pneumocystis pneumonia. Now, the part that was more concerning in the Botswana and the South African studies, but is also harder to interpret, is whether cotrimoxazole is driving resistance to other classes of antibiotics. In the South African study, they found that the number of genes carried by bacteria, which are all types of resistance genes, were higher in the children who were on cotrimoxazole, but they didn't break down in that study exactly which genes were being carried. So we can't speculate on which classes of antibiotics might be affected. In the Botswana study, they found high rates of resistance to amoxicillin. But again, that's a little bit hard to interpret. Firstly, because there was a lot of amoxicillin resistance even before children had been exposed to cotrimoxazole. So about 70% of E. coli and Klebsiella was resistant to amoxicillin anyway, showing just how much antibiotic pressure there is in those communities where amoxicillin is used a lot first line. And secondly, although there was more amoxicillin resistance in the children who'd been on cotrimoxazole, the reverse was true at baseline. The placebo arm actually had more resistance to amoxicillin. So it's a little bit harder to interpret the data that is very rightly concerning people about whether putting a child on cotrimoxazole increases the risk of resistance to non-cotrimoxazole antibiotics. So I would say overall, two messages. Number one, we don't have much data on the microbiome. The whole study of infant microbiome is in its infancy itself. The one bit of data we do have, I think, is reassuring in terms of no major shifts in dysbiosis, which is what the authors point out in that South African study. The clear message is that cotrimoxazole resistance increases among children on cotrimoxazole. And the question that people have to balance then is how clinically meaningful is that, given that in a population like South Africa, 30% of people are on cotrimoxazole already, and yet it still works where it's most needed. So I think those are the messages from the studies. Maybe in my last minute, you asked me what else we might do. I think one question is whether cotrimoxazole would be of benefit if it was started earlier. At the moment, we started at 6 weeks of age. In the Botswana study, about 40% of children did start cotrimoxazole early, in fact, as early as 2 weeks of age, and yet there was no benefit of cotrimoxazole, at least in that context, as Catherine's pointed out, of relatively low child mortality. But they did show that it was safe to start cotrimoxazole early, so people's fears about connexurus and other side effects are very much theoretical. They haven't been borne out. Might a different antimicrobial have effects? Well, there's no data, but there's a lot of interest globally in azithromycin, for example. It has a long half-life. It gets concentrated nicely inside cells. It could load a child up for a few weeks if you gave it at birth. And I would point out that the period of highest risk is the neonatal period. And actually, currently, our interventions start at 6 weeks of age. We really miss the 40% increase in mortality that we've seen in our own studies, which is all incredibly early. It happens in the first weeks of life. So either we need to be intervening in pregnancy, we need to identify the women whose babies are at risk of mortality and intervene then, or we need to be intervening at the time of birth and giving something at that birth contact that's going to keep a child protected over those early weeks of life, whether that's azithromycin or some non-antimicrobial approach, lactoferrin, or things that are being assessed in other trials. We don't know yet, but I think we have to keep our eye on the ball and say there is a need for something. If we decide to reduce cotrimoxazole use, the problem has not gone away. There is an increased mortality in children who are HIV exposed, and it's very early in life. So we do need to think about alternatives.
Great. Thank you so much, Prof. You brought in the area of the microbiome, interesting area of study. I see a lot of young people on the webinar. I think this is an interesting area to study, but also we have to address the issue of AMR, which you have mentioned. But let me end with Professor Gibbs. Diana, you are the expert. You have a lot of experience in investigating use of Cotrim. Just remind us of the benefits, and when do you think countries in high burden settings such as ours, outside South Africa, maybe, and Botswana, when do you think our countries will be ready to move to a shorter course? And how do you think we should study this in order for countries to make decisions basing on their own informed data? Over to you, Professor Gibbs.
Thank you very much, and thank you for the invite to say a few words. I'm going to go back in history a bit, because I'm really just going to remind people of a couple of studies that showed the benefits of cotrimoxazole prophylaxis in HIV-infected children. And that's really where the focus is now. What we're talking about here is making sure you catch the ones that are infected amongst all the uninfected, and therefore that's why you're looking at those risk benefits. But there were two studies, the first from Zambia, so Professor Chintu was the first author on that, in HIV-infected children before the time of antiretroviral therapy. And this trial was done when there was actually high cotrimoxazole resistance in the country. The children, it was at a time when actually not many children were even being diagnosed very much with HIV. 540 children followed for nearly 2 years, and a 45% reduction in mortality. So the trial was stopped early. And it was a bit of a surprise to everyone, actually, that there was such a reduction in mortality, considering that there was quite a lot of resistance around. Other things, that actually growth was better in the children who took cotrimoxazole. There was very little toxicity. Neutrophils were slightly lower, but they didn't go into the range of being neutropenic. So that was published in 2004. And then a decade later, in 2014, there was a study linked to the Arrow trial, and Dr. Mutsa Bwakura from Zimbabwe actually was the first author in this paper, which was in the New England Journal. And there around 800 children from the Arrow trial who'd been on cotrimoxazole prophylaxis for 2 years were randomized to either stop or continue. And what they showed there was, that there was at least a third reduction in hospitalizations. And it occurred in all age groups, and it occurred in children, whatever their CD4 count was. So in children who had CD4 counts over 30%, so high CD4 counts because they'd been on ART for 2 years, they had just as much benefit in terms of reductions in hospitalizations. There was a very few deaths, so you couldn't really look at differences in deaths there. But another interesting thing was that the children who stopped cotrimoxazole had more anemia, and the main hospitalizations were both for malaria, which has already been mentioned, and also bacterial infections, general bacterial infections. And in Zimbabwe, where there wasn't much malaria at all, you saw the same reduction amongst the children who stayed on cotrimoxazole. So I think what these studies really help to shape the guidelines that children with HIV should stay on cotrimoxazole prophylaxis, and it continued to be a benefit when they were on ARVs as well as before they started ARVs. And that is the reason for this policy, really, and of actually continuing to provide it early on. Martina mentioned the pneumocystis carinii pneumonias, but they occur very early on. They're usually between 4 and 6 months of age. So they're in the youngest children. The studies I've talked about, these did not have much in the way of PCP. So we're talking about the additional benefits of cotrimoxazole. So I think that when you're talking about this policy and whether or not it should change, there's a couple of things I've mentioned. It's already been mentioned that it's important to look at things like retention in care for the mother, whether the mother's virally suppressed and taking her ARVs, and looking at baby testing. And so I don't think there's necessarily an easy study you can do to decide whether to shorten. I think you've got to do the kinds of things that Amy described of what they're doing in South Africa to convince countries that they don't need to have a routine policy of giving cotrimoxazole prophylaxis. Obviously, time of breastfeeding is very important. And if you've got very high breastfeeding rates for a long period of time, then the baby, it continues to be at risk during that time. And we know that about half of transmission is occurring during breastfeeding. So I think that what countries do need to do is to maybe taking that modeling study, which was just looking at different scenarios, and could maybe adapt it to look more particularly at separate countries as in order to really look at the risk-benefit considerations. But at the moment, I think it's correct that the continuing of recommendation for cotrimoxazole during breastfeeding while the baby is still at risk, and particularly where mothers may not be taking their ART regularly, is important. Thank you.
Thank you so much, Dan. Sorry, we had to go over time because of these interesting interventions from the experts, but allow me to express my thanks to all the panelists who've been able to give us some of these insights in what is going on in countries, what studies are going on, and please continue sending the questions in the Q&A section. They will be answered. I would like to pass over to Dr. Ivy Kasirie. She's a pediatric specialist who is with WHO now, and she's going to give us an overview on postnatal prophylaxis. Over to you, Ivy.
Thank you very much, Dr. Lule. Due to time, I will try to be brief. Next slide. I will just be giving you an overview of infant ARV prophylaxis, which is the administration of one or more ARVs to infants exposed to HIV to reduce the risk of perinatal infection. There is evidence which does suggest that providing ARV prophylaxis to infants does reduce intrapartum transmission risk. Basically, infant ARV prophylaxis is provided as an adjunct to maternity to prevent vertical transmission of HIV and provides added protection to the infant during a potential period of maternal viremia. WHO recommends a risk-based approach to postnatal prophylaxis. Next slide. And risk assessment is based on prevailing maternal factors that affect the probability of HIV vertical transmission. WHO defines high-risk infants as those who are born to women with established HIV infection who have received less than 4 weeks of ART at the time of delivery, or born to women with established HIV infection with viral load of more than 1,000 copies per mil in the 4 weeks before delivery, if viral load is available, or born to women with incident HIV infection during pregnancy or breastfeeding, or born to women identified for the first time during the postpartum period with or without a negative HIV test prenatally. Therefore, from this, you can see that it is clear that in order to determine the risk for an infant, one must be able to test and retest pregnant and breastfeeding mothers whose status is unknown or who were previously HIV negative, as well as be able to regularly monitor mothers on ART with viral load tests. I'll just remind you next slide. I'll just remind you what WHO recommends as ARV prophylaxis for infants. For infants at low risk of vertical transmission, they should receive a single ARV as postnatal prophylaxis for a duration of 4 to 6 weeks, either with once daily nevirapine or twice daily AZT. Infants at high risk of vertical transmission should receive dual ARVs for 6 weeks. And for those infants who are breastfeeding, including those first identified as exposed to HIV during the postpartum period, should continue with dual or single ARVs for another 6 weeks for a total of 12 weeks. And this is the enhanced postnatal prophylaxis. Current recommended agents are AZT and nevirapine. I will address the alternative ARVs later on. Next slide. In a policy review conducted in 18 of the priority AIDS-free countries, 60% of the countries reviewed adopted risk-based approach to enhanced postnatal prophylaxis. But definition of high risk was variable, while about 40% adopted enhanced postnatal prophylaxis for all HIV-exposed infants. Next. We also observed in this review a wide adaptation of enhanced postnatal prophylaxis recommendations from the risk-based approaches, which were defined differently, the regimens, which included single, dual, and triple regimens, as you can see represented here, and the duration ranging from 4 weeks to after the cessation of breastfeeding. From these observations, one can see that country programs that have different coverage and capacities for antenatal attendance, maternal HIV testing and retesting, maternal ART, maternal viral load testing, EID adherence and retention may make different postnatal prophylaxis decisions based on context. Next slide. For the implementation considerations, we have different approaches depending, like we have seen in the previous slide, of depending on context. For enhanced postnatal prophylaxis for infants, for all infants who are exposed to HIV, this may be considered in settings where majority of mothers are at high risk of transmitting HIV. For example, settings where there is poor maternal ART coverage, poor viral load coverage, poor maternal viral suppression rates. And this is an interim measure as strategies to improve maternal ART coverage, viral load coverage, and maternal viral suppression rates are put in place. So we need to also remember that when we provide enhanced postnatal prophylaxis for all infants who are HIV exposed, there are implications on cost and stocks of ARVs, and this may also unnecessarily expose infants who do not need enhanced prophylaxis to ARV toxicity. Another consideration is extended or prolonged postnatal prophylaxis. Although supportive evidence is limited and WHO doesn't explicitly recommend it, infants and young children who remain at high risk for HIV transmission during the breastfeeding period may receive extended prophylaxis beyond the recommended 12 weeks as a provisional backup until the risk is considered limited or has ceased. That is when a maternal ART is established, adherence improved, and viral suppression is achieved. Circumstances that present a persistent risk to breastfeeding infants include maternal inability to start ART or continue ART, maternal poor adherence, maternal viremia when the infant prophylaxis is about to be stopped, and poor retention and viral load monitoring. However, we need to emphasize that priority remains attaining maternal viral suppression as quickly as possible. However, despite that, the focus on maternal interventions should not mean losing focus on the HIV-exposed infant. Efforts to ensure retention in care throughout the period of risk are fundamental. To note is that once an infant has had their prophylaxis stopped, it should not be restarted, even with new concerns about maternal adherence. Next slide. This is just the simplified age-based ARV dosing chart for administering enhanced and prolonged postnatal prophylaxis, where we also provide dosing for nevirapine up to 24 months of age. We also, at this point, also include alternative ARVs which may be given in special circumstances, for example, stockouts of nevirapine or AZT, and these include giving of raltegravir, and we give this at treatment doses. And based on evidence from the PROMISE trial, 3TC on LPVR may also be given as follows. 3TC may be administered initially at 7.5 milligrams daily, and from 4 kilograms and above, 4 kilograms to 8 kilograms at 25 milligrams once daily, and 50 milligrams once daily for children greater than 8 kilograms. LPVR may also be used as postnatal prophylaxis after the first week of life, according to the dosing scheme that is indicated there. Next slide. There are still several research gaps for postnatal prophylaxis, and this will be addressed later in the panel discussion. However, what we need to understand better are the additional benefit of combination of prolonged infant prophylaxis with maternal ART, which still remains uncertain. There is limited evidence for infant prophylaxis for infants with HIV exposure identified during the postpartum period or incident maternal HIV infection during pregnancy and the breastfeeding period. Clinical and pharmacological studies need to be carried out to inform development of alternative ARVs and formulations for prophylaxis. There needs to also be evaluation of clinical relevance of viremic episodes in the breastfeeding mothers and determination of the optimal definition of high risk in the context of universal ART in different settings. The impact of various service delivery models on adherence to enhanced postnatal prophylaxis and retention needs to also be more clearly understood. At this juncture, I would like to invite some of our colleagues from different countries to present to us their experiences in providing risk-based postnatal prophylaxis, prolonged prophylaxis, and prophylaxis to all exposed infants. We would like to hear your experience in these different approaches. I will start with Dr. Danielle Simnyo Nem from Cameroon, the WHO office in Cameroon, who will be giving us the experience of Cameroon in providing postnatal prophylaxis in a risk-based model. Over to you, Dr. Danielle.
Okay, thank you, Ivy. Thank you. Good evening. Good morning to all. Thank you for giving the opportunity to present you the comprehensive package of care for children under 2 who are HIV exposed and uninfected in Cameroon. First of all, you should know that when the first early infant diagnosis is done here at 6 weeks, and when it is negative, the infant has to receive the comprehensive package of care below, in the yellowish circle in the middle of my slide. You have prophylactic IV. It's given from birth to 6 or 12 weeks, depending on when the mother started the ARV treatment. Psychosocial support for caregivers, growth monitoring by measuring length, so it's not height, it's length, weight, head, and arm circumferences of babies, psychomotor surveillance, regular full clinic examination, and from 6 weeks to 6 months, it is done monthly, and from 6 months to 24 months, it is done quarterly. Nutritional counseling, vaccination, cotrimazole from 6 weeks until there is no risk of HIV transmission. So as long as the baby is breastfeeding, you have PCR at 9 months and serology at 18 months. How was it implemented? First, by integrating this comprehensive package of care in the national guidelines in 2019, and by the training of some health workers on the package of care. What is not working? What is working, please? Prophylactic ARV. It increased from 83.5% in 2018 to 87.5% in 2019, but dropped in 2020, maybe due to COVID-19. Also working is research of exposed children in the community by community workers. Catch up, some exposed babies are catched up through the vaccination unit or the hospitalization ward. What is not working? Most of the children don't receive the comprehensive package of care, but an incomplete package of care. And we also have problem with the cohort monitoring of the couple mother baby until 24 months. Why is it not working? First, we have stock out of cotrimazole. Actually, cotrimazole is available, but mothers have to pay, and sometimes they don't have money because free cotrimazole is stocked out. We also have problem with insufficient knowledge and implementation of growth surveillance of babies by health workers. We have lack of task shifting, poor cohort monitoring system. Another problem is that mothers are not motivated to go for regular clinic examination when the babies seem healthy. Psychosocial support is not systematically given. And the PCR at 9 months is not systematically done. We also have problem with accessibility of point of care. And finally, serology at 18 months is not systematically done. Thank you, over.
Thank you, Dr. Danielle, for that overview from Cameroon. I would now like to invite Dr. Francis Ndwiga from NASCOP Kenya to provide us their experience in providing postnatal prophylaxis over the entire breastfeeding period. Over to you, Dr. Ndwiga.
Okay, thank you very much, Ivy. This is David representing Dr. Ndwiga. Apparently could not make it to join the meeting, but I'm here to share our experiences in terms of offering the extended postnatal prophylaxis. Next slide, the first slide. So for us as a country, we started implementing this extended PNP in 2018, when we changed the prophylaxis from 12 to 24 months. And so Kenya has implemented exclusive breastfeeding and we advocate that these mothers continue breastfeeding up to 2 years for HIV positive mothers with treatment and prophylaxis. And this is extended up to 6 weeks after complete cessation of breastfeeding. What you've also learned from our UNAIDS stack by analysis is really like what Diana mentioned, that we're seeing most of our children getting HIV infected during the breastfeeding period, other than during the period of pregnancy. And so the role of postnatal prophylaxis, extended postnatal prophylaxis among the breastfeeding infants cannot actually be emphasized. Next slide. So this is how, as a country, we do our prophylaxis, all infants, irrespective of the HIV status, are actually exclusively breastfed for the first 6 months of life, with a timely introduction of appropriate complementary feeds after 6 months. Thereafter, they continue breastfeeding up to 24 months and beyond. Then all HIV-exposed infants also receive ARV prophylaxis, consisting of, they do 6 weeks of azathnevirapine, and thereafter they do nevirapine until 6 weeks, which is discontinued until 6 weeks after complete cessation of breastfeeding. Then we also discontinue the infant prophylaxis after 12 months, after 12 weeks rather, if the child is not breastfeeding, for example, in case of the death of a mother or separation of the infant from the mother. So that is just a quick snapshot of what we are doing as a country. But in terms of lessons learned, just like I've mentioned, one of the issues that we've experienced is the issue of stockouts of nevirapine especially. Because I think in terms of our projections, we had a challenge with that. And so the extended PMP has really made us get into stockouts of these commodities. And certainly, which is a factor that we feel has led to the reversal of MTCT in Kenya. The other lesson learned is the issue of involvement of the community, especially utilization of the community strategy, so that we can have these mothers actually adhere to treatment, and also make sure that at least the mothers really know what is expected in terms of offering this extended PNP. The other challenge that we've also had with this is in terms of capacity building of our healthcare workers, especially the nutritionists and the nurses, so they can actually be able to give this information to our clients. The other key challenge that we've also had is the issue of non-adherence, especially for mothers. You know, this leads to these mothers not being very suppressed. And actually in the WHO guideline, you know, it's not very explicit in terms of how do we go about the issues of mothers who are not really adherent to treatment. And then lastly, we also have quite insufficient data in terms of the ADRs, the adverse drug reactions, especially for these children who are on extended PNP. So I think that's a snapshot of what we are currently doing. Also to mention is that we are currently using the 2018 guidelines, which didn't have really great alternatives for the other alternative regimens that can be used. But I'm glad to see what Ivy has just presented. And as a country, we are actually in the process of reviewing our guidelines. And so probably that will be included in our next guidelines. Over and thank you.
Thank you very much, David, for that presentation. And finally, I would like to invite Dr. Beatriz Simeon from the Ministry of Health of Mozambique to present their experience in providing postnatal prophylaxis to all HIV-exposed infants. Over to you.
Hi.
Hi, Dr. Beatriz, go ahead.
Hi, thank you, Iva. Good afternoon, everyone. My name is Beatriz Simeon. I'm going to share with you our experience in Mozambique on adoption of prolonged exposed postnatal prophylaxis for exposed HIV infants. Can we go to next slide, please? As you know, the 2016 WHO guidelines recommend risk-based assessment for all HIV-exposed infants at birth, using the criteria regarding viral load coverage HIV test result during the delivery or postnatal period, and the duration of ART for pregnant women and in period of postnatal. We started revising our guidelines in 2019, and we looked at all these indicators before we decide if we can adopt or not the prolonged extended postnatal prophylaxis for all these kids. The points that we looked at was the viral load coverage for pregnant and breastfeeding women. And as you can see, our coverage was the big issues for us in Mozambique. In 2019, we were covering only less than 40%, 14% of the pregnant women on viral load. By June 21, we have a quite improvement, but it's still not in the range that we would like to reach. We are in 56% only performing viral load among pregnant women. Looking at viral load suppression, we still quite acceptable, up than 80%, 87% for pregnant women, viral load suppression, and 89% for breastfeeding women. Another issues that we were looking at was the MTCT rate. Now in Mozambique, the MTCT rate is 12%. The pregnant woman ART coverage was not our problem because we reach 90% on ART coverage, but the big issues is the duration of ART. Most of our pregnant women reach the first ANC up than 28 weeks. The average at first ANC average of gestational age is 20 to 28 weeks. Only less than 16% reach with less than 12 weeks. Other point is the positivity on the CCR for positivity of PCR for exposed infants. Even though our positivity within 4 and 8 weeks reduce from 9 to 4%, the transmission during the breastfeeding is quite high. We reduce from 21% to 14% up than 8 weeks, but 14% we consider quite high. And the other point, additional point, is that our breastfeeding duration in Mozambique is around 12 to 18 months in our population. That's why we think that the breastfeeding is a period of the continuous HIV exposed and the risk of infection of our kids, and the risk assessment is difficult to implement due to these all issues. And the mom viral load results is often variable. They don't keep suppressed during all breastfeeding duration. Thank you, Eve. That's the point that I will share with you. Over to you.
Thank you very much, Dr. Beatrice. Thank you all the country presentations for giving us a very interesting overview of the decisions that your country has made based on the context. Without further ado, I will move on to the next session, which is a panel discussion. I will be handing over to Moko Newman. Dr. Moko Newman Owiredu is a medical officer and focal point for elimination of vertical transmission and women's health in HIV at WHO in Geneva. Over to you, Moko.
Thank you very much, Ivy. And we've had a very interesting session so far. This next session, for which we have two excellent panelists joining us today, and very early in the day on their parts, thank you. And we will be discussing postnatal prophylaxis. Now, we all acknowledge that this is a very critical time in the life of both the mother and the infant. And in the postnatal time, we can either consolidate our gains or lose them all. So the postnatal prophylaxis, as has been presented, is a very critical adjunct, but it sadly still needs a lot of prioritization if we really want to ensure uptake and access of this intervention. So we remember also that we have two individuals involved, the mother who administers the drug and the child who needs the PNP. So not without much ado, I'll first introduce Professor Elaine Abrams, who is affiliated with both ICAP at Columbia University and the Impact Network in the USA. And our second panelist, Professor Theodore Ruhr, based at University of California in San Francisco, that's USA. I have two questions for you, Elaine. There are several ARV drugs which are currently used for treatment, yet we are still remaining mainly with the use of NVP or nevirapine for postnatal prophylaxis. Could we use other drugs beyond NVP and AZT? And if not, what is the evidence that's missing? And our second question is, currently the dual ARV regimens are recommended for high-risk infants. However, the triple regimens are also being used and considered. So what are the advantages and disadvantages for both these options? Over to you, Elaine.
Well, thanks so much. I'm so pleased about your introduction where you emphasize the connection between moms and babies, because this is not just about what we give the babies, but it's about the dyad and starting in pregnancy and then throughout the breastfeeding period. But when we talk specifically about the ARVs and your question of why are we still using these antiquated agents that they barely talk about it for adults, I think we know that historically a number of drugs have been tested for efficacy for postnatal prophylaxis. 3TC, for those of you who remember D4T, maybe DDI, and lopinavir ritonavir liquid has also been tested and all shown to be efficacious to prevent acquisition of HIV during breastfeeding. However, we've not tested any of the new exciting agents, particularly dolutegravir, raltegravir, abacavir, have not been trialed for postnatal prophylaxis. And there are a number of really exciting new agents that are being looked at in the adult community for prevention, including cabotegravir, which has already been demonstrated to be quite efficacious for prevention of new infections in adults. So what evidence do we need to be able to use an ARV for postnatal prophylaxis? I think first we need a formulation that we can give to newborns and infants. We need to know how to dose that agent, particularly in the newborn period, and ideally for premature babies, since we know infants born to women on ART may be at increased risk for prematurity. We need to understand the safety or potential toxicities. We have lots of experience in doing those kinds of studies, but we need the agents to be able to study them in that way. And as I said, there are a number of new agents in the adult space, islatravir, lenacapavir, that have some very interesting attributes that we probably want to bring to the pediatric space. I think the second really important question is efficacy. Do we need to treat new agents that we want to use for PNP for efficacy to demonstrate that they do prevent acquisition of new infections during breastfeeding. We have to test each agent. If an agent like dolutegravir is demonstrated to be effective for treatment, rapidly reduces and sustains viral suppression, can we just assume it'll be effective for postnatal prophylaxis? Or if we see an agent effective for prevention in adult sexually acquired HIV, can we assume it will be effective in postnatal prevention? And if not, if we have to test these agents, how do we do that in the context of improving maternal viral suppression and retention, better agents for moms? Some people feel that we really don't need any postnatal prophylaxis, that we have to focus on just engaging every mom and making sure they're suppressed. So there are a lot of interesting questions. And I think finally, we're at this last frontier of trying to identify the drugs that we think would be best used in this space and to test them, to get the right formulations and then to test them. Very briefly onto your second question. Many guidelines groups have spent many hours debating the question of 2 versus 3 agents for high-risk infants. And we need to consider several issues, efficacy, toxicity, and resistance. And unfortunately, the evidence base is quite thin here. We know that 1 versus 2 agents, directly after at delivery, we have evidence that 2 agents work better than 1 to reduce the risk of perinatal or delivery and late in utero transmission. But we have very little evidence of more is better as you go on through breastfeeding. The advantage of a 3-drug regimen for high-risk infants is that you're essentially starting presumptive treatment among a group of children or among a child where you think there's a high risk the child will be infected. This allows you to treat the infant as early as possible, and gives the benefits of early treatment. So at birth, it will also likely limit establishment of the reservoir. During breastfeeding, it could be life-saving. We did a recent study in Mozambique looking at retesting moms who are negative, who bring their babies to the immunization clinic. And 20% of the babies born to moms who tested positive in this retesting program turned out to have HIV infection. So that's a very high rate, and you could see the benefit of starting the 3-drug regimen. 3-drug regimens likely have somewhat more toxicities than 2-drug regimens, though we're using well-established safe drugs. If you just have a 2-drug regimen, you will also have increased risk of selecting out resistant mutations if the child is indeed infected. So in the end, you can see the advantages of 3-drug regimen in very high-risk situations. I will add that if you have point-of-care EID and can test the babies before you initiate 2 or 3-drug regimens, you can address this issue and start those identified as infected on treatment. So I'll end with that and turn it over to Ted so we don't run out of time.
Thanks so much. Very important points, Elaine and Ted. And several infants who are HIV exposed are only identified when they present sick. now, or through other case finding modalities, which are outside the PMTCT or AID cascade. So just quickly, we would like to know how programs should approach postnatal prophylaxis under these circumstances, especially if they're breastfeeding and their mothers are not on ART. So the first question is, could you give a sense of what is available on the horizon for PNP options? And should we be optimistic about these options on the horizon that could not only be effective, but also convenient for the mothers and their babies? And lastly, in some countries, mothers living with HIV breastfeed for long periods. They provide postnatal prophylaxis throughout these periods, and we'd like to know what the pros and cons of this approach are. Over to you, Ted.
Great, thank you for those three great and important questions that I think we're spending a lot of time thinking about these days. To the first, this is the infant who presents ill, basically being identified as exposed to HIV outside of the standard kind of testing programs. I mean, I think this is a scenario that unfortunately I'm sure many people know well, and until we have 100% complete coverage of women with HIV being treated, this is going to occur and infants are still going to come through. So it's important we have an approach for this. That said, as Dr. Kasiria pointed out, this is also an area where we don't have robust data on the optimal approach. And so our answer in the guidelines is really just based on first principles and kind of imagining that this is a very high risk infant at birth, kind of even more so. So along those lines, I think the first is recognizing this infant in front of you is exactly that, extremely high risk. So of course, testing will be the first thing that needs to be done. If point of care testing is around, this would be a great moment for it. You don't want to lose track of this infant. You want to get this infant into care as quickly as possible. But of course, sending any kind of nucleic acid based test or NAT test would be important right away. So that would be the first step. And this is recognizing this infant may have been infected for now months, depending on how old the child is in front of you. The second is how to approach the use of antiretroviral medications in this infant. So again, I think we have to imagine this as, had this child been born in this scenario, we would have considered this child high risk. But now it's just even more so, with perhaps longer period of time to have been infected, longer period of time to be living with this infection and becoming more immune compromised and sicker. So for that reason, I think the guidelines are to use what Dr. Evans was talking about, kind of presumptive treatment. So no longer is it just 2 drugs to have extra prophylaxis. You want to provide this infant treatment as soon as possible. So with the first regimen given, and that should be continued until you know this child is not infected. So until that result comes back from the test that was sent when you started. And then what you do after that, it begins to fork in different ways. Of course, if the infant is infected, you will continue the treatment. If the infant is shown not infected at that time, you'll kind of de-escalate, but this child should still get the kind of treatment you would have given an infant that was born in this high-risk period. So we'd recommend continuing probably 2 drugs, certainly 1, at least for the full 12 weeks. That is usually considered in that period. And that's, of course, to give time for the mother who has just been diagnosed to begin her treatment and become suppressed. And then what you do beyond that with prophylaxis is the infant begins to then just get treated as others that have been exposed. So if you have ongoing concerns about maternal adherence or access to treatment, then you may or may not continue extended prophylaxis as per your country guidelines. So I think in the end, you end up ideally, this child gets back into the just exposed infant long-term follow-up. But again, super critical to do all this with the closest of care, with urgency, and staying in touch with this family. This infant's at very high risk of becoming ill. You'd want to be sure that this kid, of course, let's not forget, gets managed for the illness with which they presented. So with considering things like pneumocystis and other opportunistic infections, because the infant's very high risk. So I'll turn to the next question, which is, what options are available on the horizon for postnatal prophylaxis? I'd say we're at a very exciting time where our look into the future is becoming more and more interesting with new agents. I think, as many can appreciate, we are in a very different place now than we were 10, 20 years ago, with very powerful, very well tolerated once daily oral regimens for the world. In this case, dolutegravir based right now that are giving us unprecedented kind of levels of suppression and just ease. But it's time to now look, well, what's next and what's better? And the real focus in research across the world has been around long-acting agents. So these are drugs that have very long half-lives that stick around for a while, and platforms, different ways to give the medicines to people that also help these drugs stay longer concentrations for longer periods of time. It's very exciting, and we've seen some hints for many years, but some of them are getting closer and closer to being studied in trials in adults and therefore closer in kids. And just to give some tantalizing examples, one drug called islatravir, you can take a single dose by mouth and it lasts a month. So this would be a once monthly oral dose. And you can imagine when it's used in something like an implant, this can give you durations of up to 6 months or even longer. So really kind of fun to just imagine what it would be like for someone to get an implant that meant they didn't have to take any medicines for 6 months. That's the fun way to think about it, or I should say the dream that we have. But unfortunately, we're still a bit far away from this becoming a clinical reality for people living with HIV right now. The combination that was closest were these IM injections of cabotegravir and rilpivirine, which have been approved in the US, but I think there are many challenges with implementation and concerns about resistance that it's not likely that this is going to be the long-acting platform that takes over the world. So I think we'll have to wait a bit, but very exciting options there in adults, and of course very exciting in children. But as everyone on this call knows, we can't presume what works best for an adult is going to work well for children. We need to make sure which of the best is going to work for babies' bodies and be able to be implemented with comfort by families globally. So an exciting future, but still a bit away. Stay tuned. And the final question was around, I believe it was breastfeeding and providing prophylaxis during the period. What are the pros and cons of this approach? I think Dr. Abrams touched on a number of these issues, but just to review, this is again an area that I think we need to reopen. I think for many years we've been giving the same things. I mean, zidovudine, as a reminder, was the first drug we used to treat HIV, and yet we're still giving this to our babies. It works pretty well, and babies tolerate it. But we want to bring a next generation regimens and medications to babies that are even safer with less anemia and such. So we really need to work in this space. So what would be the pro to giving babies medications in this period? I think it should be fairly obvious. The goal is to get to zero. We want women to feel comfortable breastfeeding around the world, not with just a little risk, which is what we now have if women are taking their medicine, able to take their medicines most of the time and achieve suppression. But the goal is to get to just 0-0. So there is breastfeeding without concern. And if we had a very, very safe and well-tolerated regimen, for instance, again, if we put in our imagination about the long-acting, you were able to give a baby a shot at birth that lasted 3 months, that would be a magnificent option and for people to be worry-free. But of course, we're not there yet. And so the cons to giving medicines to babies are several. You have risk of toxicity, as we know. You have risk of babies, if you're not using a full regimen, of infants that do become infected, having resistance to that regimen. And of course, as everyone appreciates, whenever you're giving a baby a medicine, it runs risks of privacy for the mother and disclosure and unwittingly in the home or in the community. And so there are also many issues of just physically giving these to babies that we have to concern. So I think this is, again, a very important space for new research. I mean, we need to think about how the long-acting things may help us in this space, but we need to start where we are and move ahead. It is great that we've gotten transmission to the rates we have now, but we need to keep moving ahead to 100% safe breastfeeding for women and their infants. So I think that's, maybe I should wrap up there as we've hit the end of our time, and I'll hand it back to Dr. Ogrereru.
Thanks so much, Theo, and thanks also Ted so much, and thanks Elaine. I think we've had an exciting time with our two panelists. The exciting way forward, there's so many new things for PNP which are up and in promise at this time, but even if we are far from them, and we recognize that there are many risks and issues to be dealt with, it's good to know that we have a way forward to think through. So I think we've almost caught up with time. I'll hand over to Ivy now to wrap up and do the summary. Thanks.
Thank you very much, Moko, and thank you to all the panelists for these excellent insights. Truly an amazing experience for many of us. I'll just go through quickly a brief summary of what we've enjoyed today. We started off with Martina giving us an overview of the comprehensive package of care for infants and children under 2 who are HIV exposed. And we just highlighted that the package comprises both maternal and child interventions aimed at HIV-free survival and optimal development of infants. The components include maternal testing, treatment and monitoring, early infant diagnosis, infant ARV prophylaxis or postnatal prophylaxis, cotrimoxazole prophylaxis, and early childhood development. Next slide. We had 2 presentations on cotrimoxazole prophylaxis and infant ARV prophylaxis. I won't go through everything, just to remind you that we presented the recommendations for HIV prophylaxis and the implementation considerations for infants in low and high risk settings. And we had discussions on how the countries can, what the considerations are in preparing to move to different, to shorter implementation of cotrimoxazole. For ARV prophylaxis, we discussed what the recommendations are. WHO recommends a risk-based approach, and for enhanced prophylaxis is a 12-week regimen for HIV for high-risk infants. Key to note is that the most effective intervention is maternal viral suppression throughout the period of risk. And Moko will, always reminds me maternal suppression even before conception, with effective ART and adherence. We had country experiences in the adoption and provision of different approaches of postnatal prophylaxis, and this was based on their contexts. We had the experience, and we've also just heard about the pros and cons of some of those approaches, especially prolonged postnatal prophylaxis. Next slide. And finally, we had 2 very interesting panel discussions with the experts in the field. Zambia shared the experience in the implementation of cotrimoxazole prophylaxis and the other components of the package, while South Africa's experience was shared in the adoption and implementation of the shorter course of cotrimoxazole prophylaxis. We also heard what the clinical relevance of microbiome disruption and antimicrobial resistance is, and the overview of the history of cotrimoxazole prophylaxis and insights on indicators of readiness in high burden settings to move to shorter course of cotrimoxazole prophylaxis. For infant ARV prophylaxis, we explored alternative exciting ARVs on the horizon. Very interesting discussion. And we learned about the advantages and disadvantages of using dual versus triple ARV prophylaxis. What many programs struggle with is postnatal prophylaxis for infants who are exposed late, who are identified late or outside the PMTCT cascade. And Professor Ted has really given us a clear explanation on what countries can do, country programs can do in those situations. And we heard about the insights of the future options and a summary of the pros and cons of prolonged prophylaxis. With that, we've come to the end of this webinar. Next slide. Before we leave, I would just like to once again reiterate the importance of family-centered model of care in these difficult times in many settings with several restrictions. For us to all take into consideration this approach at every contact with families, to provide a comprehensive package of care at any contact that you may have. Next. And once again, this is a highlight of the AIDS-free toolkit. Next slide. Next slide. This is the AIDS-Free Toolkit, where you'll find several resources, including what is new right now on the toolkit is the pediatric ARV dosing dashboard, with information with the drug dosing tool for ART for children from birth to 18 years old. And the next slide. Another new entrant on the tool is the policy brief for transitioning of to the optimal ART regimens. Next. We would also like to remind you of the upcoming webinars. Please do not forget that we have the WHO ECHO webinars every first Tuesday of the month. We have the next webinar on 2nd of November, which will be about providing quality services to adolescents and young people living with HIV. What are we doing right and what are we doing wrong? This will be a very interesting webinar with a lot of input from young people on this subject. The webinar in December will not be on the first Tuesday because of the ICASA conference. It will instead be on the 14th of December, and it will be on index testing. Next. I would now like to invite Daniela Mark from PATA to kindly give us a highlight of what is on the horizon from our partners, PATA, in the coming months. Over to you, Daniela.
Thank you so much. So I won't be long. I just wanted to give everybody a quick update that there are 3 very exciting pieces of work that PATA is undertaking that we would like to invite you all to participate in. So number 1, there are 26 days to go until the PATA 2021 summit. As many of you will know, PATA has been holding summits for 17 years. So this is our 17th summit, and the summits are focused on children and adolescents living with HIV, which I know everybody on this call is focused on and interested in by virtue of you being here. But those of you who've attended summits before know that PATA summits are not like traditional conferences. They really are geared towards frontline health providers and providing a platform for peer-to-peer learning. And, you know, until COVID hit, those were always in person in a specific country. But since last year, we now have a hybrid delivery of the summits. So we have an online attendance, which is open to everybody. And then we've also got in-country satellites, which are taking place in many countries this year. There's no registration fee, and all you need to do is complete a very quick application online, and then we will send you either to the online hub or to your country's satellite in person. So I'm going to pop the link in the chat now. We also wanted to share that we have a COVID survey that is going on at the moment, and this survey is very important because it provides information for policymakers and people in your countries who are able to really support you as frontline health providers around COVID and training and support that you may need if you are a health provider. So please complete that. I'll also put that in the box. And finally, PATA has launched an online hub, which we are using as a platform for webinars and trainings and all sorts of brilliant resources for frontline health providers. So please join that hub and you will be notified about all of these things. And that is it. Over and out. Thank you so much to everybody, and back to Ivy.
Thank you very much, Daniela. And I still have more on the menu for all of us. Just to remind you that we have the 3rd Pediatric and Adolescent HIV Learning Collaborative for Africa, the PALCA event that is taking place on the 20th and 21st of October 2021. You can see the times over there. And finally, next slide. We will also, I would also like to highlight the IFASA, the first IFASA conference, which is the first International Pediatric HIV Symposium in Africa, which will be taking place on the 17th and 18th of November, with the theme, Leaving No Child with HIV Behind, looking at efficiencies, innovation, and stakeholder engagement in service delivery. This is organized by Ministry of Health Uganda in partnership with CIPHER, from the International AIDS Society. Please register for this symposium. It's an online virtual symposium. Register at www.ifasa.org. The conference is free. The symposium is free, so please register and participate in that event. With that, final slide. With that, I would like to conclude this afternoon by thanking everybody. Special thanks to the presenters for their very interesting and informative presentations, and to the expert panelists for participating in their very rich panel discussions and sharing their extensive expertise with us. Special thanks also go to those involved in the preparation and coordination of this webinar, and to all the participants. We've really had a big audience today. Thank you very much for attending. Thank you for your attention. Until next month. Bye to everybody.
Bye-bye.
Bye.